Thank you, Srini, for fair disclosure. I didn't actually found Viva. I was on the board for a while, but much smarter people than I were among the founding group. So it's my pleasure to be part of this session today and to sort of spearhead this, speaking about access and crossing techniques for SFA CTOs. Obviously, is a very common problem, and you can't fix that problem until you can cross that lesion. So why don't we jump right into it? These are my disclosures. There are really no disclosures specific to this talk. Obviously, I work with a lot of companies, and we use all of these devices in this particular vascular environment. So CTOs, as I said, are a very common problem. This is not unique to you guys. I'm sure you encounter these every day, and you find CTOs in the femoral popliteal distribution in approximately 40% of cases of patients who are symptomatic with this disease. And they're not easy to cross. It's not uncommon to require some sort of adjunctive technology, or I should add technique, strategy to cross these things. And as we do more complex lesions increasingly, we have a greater need for some of these new technologies and strategies. And I will say there's no gold standard. As I'm going to show you here is a series of case presentations. What we do, it may be different from what you do, but it does reflect my experience now over my 30 years of sort of treating these sort of lesions and what we've evolved into doing. There are a number of devices which are CTO dedicated devices for intraluminal crossing in an antegrade fashion. That is either contralateral femoral approach or antegrade from the same legs groin. And you can see here these are all listed. Each of these has various advantages and disadvantages. It's not my intent to go through each of these in detail or to show the data around them, but I always say it's good to have familiarity with one or two devices in your lab that you can utilize on a appropriate case basis as you become comfortable with them. As just an example, this is the Wingman. This is one that we use on occasion. This is a braid reinforced hypotube microcatheter. What I like about this one, it actually has a penetrating needle which you can engage and twist to get through that proximal cap. Again, however, with all of these CTOs, you have to work in relatively straight segments, or you have to be angulated or appropriately oriented in the vessel to treat it. So here was this case. You can see this dense calcific CTO. You'd think we'd be able to get across this with wire catheter techniques, but we were not having any success. Obviously, we can always come retrograde, but before we did that, sort of seeing where our catheter was located and seeing the angle of attack for this particular lesion, we took that Wingman, popped through that cap, wire went, and then we could go ahead and complete the case. In this case, some orbital atherectomy because of that calcium, followed by some DCB, and you see the result here. So, clearly these things have a role, but let's go back to the primary question, and I've given this talk a number of times. When you're treating femoral popliteal CTOs, do you need to be intraluminal or subintimal? And if you sort of ponder this, I'm sure you've all done both, right? And you kind of take it as the case allows, but there is some science behind this, and I'll show you some cases as well, how we sort of go through this evolution. So intraluminal is harder, but theoretically preserves treatment options. Obviously, you can do plaque modification, and debulking if you want to. It's more device intensive and more expensive, and patency is definitely lesion length dependent because you're going through that atherosclerotic lesion entirely. Potentially greater embolic risk as well because you're working through that debris-laden atherosclerosis. Subintimal, at least in our experience, has been faster and more reproducible. I mean, I can do an SFA CTO if it's accommodating in 30, 45 minutes, so it's definitely made things easier. But re-entry can be a challenge, as I'm going to show you. And what you don't want to do is now extend that subintimal plane past the point of reconstitution and across critical collateral vessels and have worsening ischemia. That re-entry can particularly be a challenge when you have a lot of medial calcification, and I'm going to show you some of those cases. So there is one sizable trial. This is actually not new anymore. This goes back to 2013, looking at subintimal versus intraluminal approach. This is an interesting sort of trial where patients were randomized, as you can see, to either intraluminal or subintimal, but there was a large crossover. So at the end of the day, essentially the same number of patients had intraluminal and subintimal. 54% were treated with intraluminal recanalization, 46% were subintimal. And you can see here, some other things, including, by the way, retrograde access in more than a third of cases in both of these groups. A fair amount of IVUS, which should be increasing. And this is the take home. There's no difference in patency, and this is out to 3 years. So, while you might think that one strategy is better than the other, the data doesn't necessarily bear that out. Obviously, assuming that you have good completion of the case with good luminal gain and preserved runoff. So let's do this really quickly, a series of cases, how we sort of go through the complexities of this. SFA CTO, profundus stenosis, you can see that on the left here as well, reconstitute at the level of the adductor canal, a fair amount of calcium. Our strategy, up and over, actually use that sheath dilator very often if we can to engage that ostium of the SFA. Knuckle a wire down. Generally at that point, we like to go ahead, and actually it's a different case, we like to go ahead and just take a 5 millimeter hydrophilic coated balloon and bring that, usually an 035 approach in our case. Here we see it again. This one has a little bit of proximal SFA that you can see, reconstitutes a lot of calcium. Once you engage, now you knuckle that wire down, you come down sequentially. Here's actually the tip of the balloon, and as you know, you kind of advance, so you get that knuckle, and then you advance the catheter or the balloon. You shorten that knuckle so it's in the range of about 3 to 10 millimeters, and you sequentially sort of do this until you get down to the point of reconstitution where theoretically, down here, you now spontaneously pop back in. The trick there is, if you have a good outward directed wire, let's say a glide wire advantage or something similar that you might be familiar with, you want to shorten that loop so it's got springiness in it, it's got outward turgor and it wants to find the lumen. And obviously once you complete this, particularly if you've crossed with a balloon, then you just go ahead and pre-dilate and make decisions regarding further management. In this case, we treated this one, there was a atherectomy up top in areas that we were intraluminal, and then completed this case with angioplasty, as you can see. And again, we used a fair amount of DCB. And this is actually very good. We know that DCB in these long lesions, and this is not a data talk, can be very, very good. Here you can see this is an average lesion length of 24 centimeter, and yet patency here out to a year, and this between 77 to 82%. Let's jump more into the case examples. Again, here we have an SFA, proximally patent. The rest of it's a long CTO. We constitute the junction of P2 and P3. And we've sort of come down here. And what I'm showing you here in this technique is that sometimes, even though I'm subintimal, it's difficult to migrate your tools, especially if there's calcium, there's a lot of drag and friction on the system. So often, if you have a balloon, you're kind of dilating as you go to creating space. But if you do that, don't dilate down to the point where you may want to use a re-entry catheter because you created too much space and your needle now won't bridge over into the patent lumen. So you can see I sort of stopped short with my balloon here, not all the way to the point where I'm going to plan to re-enter based on the angiographic demonstration of reconstitution. In this case, we kind of thought we had it. Then we get down. We have some angiographic sort of dead end over here. So despite my most recent advice, we were able to sort of get down here, target towards what is now the true lumen. I was a little bit surprised by this wire hitting that angiographic dead end, and then of course re-enter. And of course, using the L and T configuration to make sure you align appropriately with the target lumen. Once we complete that, then we can sort of balloon this appropriately now and finish up your case as you see with the result here. And again, the details of the completion are up to you. I'm going to show two of these cases because there's been quite a bit of interest in this in the real world and in the Twitterverse. So this is a patient who has a adductor canal occlusion extending into the popliteal. And in this particular case, this is a retrograde tibioperoneal trunk or P3 popliteal puncture. We no longer prone these patients. So obviously we tried to cross these lesion antegrade. We were unable to do so. You could have gone to the foot, but look how gracile and calcified these vessels are going down to the foot. So this is actually our preferred approach. This is supine, ipsilateral, anterior oblique until you find a window either by calcium or road mapping for puncture of the P3 popliteal or tibioperoneal trunk. And as you just saw, you kind of advance this sort of like landing a plane into that runway. And you can see the very, very end of this active sequence here is kind of pushing, and then it will kind of engage and pop in, and obviously at that point you're going to get some blood return. So there it popped in. Now you can pass your wire. Now we have bidirectional or rendezvous techniques that we can utilize. In this case, this is that obligatory slide. This is all commonplace to, this group of operators, but, for certainly those people who haven't done this, is an 035 catheter from the top and 014 retrograde wire. Both need to be angled so you can deflect off the wall, and then you capture this with through and through access, and then you're going to go ahead and complete your case, whoever you might like to complete the case once you've gotten recanalization, so you can then proceed with revascularization. Let's keep going through these really quickly. Here's a patient, long SFA CTO. I'm going to keep saying that. here we go. Now we've dilated up the track. We're sort of trying to find our way back in. Not successful. Again, there's another retrograde P3 puncture. I'm going to show this one for a slightly different reason. Here we get access clearly in that P3 segment, a little bit higher up. You can see how steeply we oblique this in the ipsilateral anterior approach. This one was done with road mapping, so we can see where we're punctured. You come right underneath the bone there, past the wire. Here's that same antegrade 035 wire, retrograde 014 wire, and then we complete the case. But the reason I wanted to show this one is there's been a question, let me go back. There's been a question about hemostasis at that puncture site, and there's any number of ways to do that. In that last case I showed you, there's actually balloon hemostasis, so once you cross successfully, you redirect your wire down, inflate a balloon across that retrograde popliteal or tibioperineal site, keep that inflated for 3 to 5 minutes. This is a little bit different variation on the theme, and what you can do in this case, since we often have a microcatheter retrograde, once you sort of get that balloon in place, you back out that microcatheter. It looks messy, but this is by intent, so that you know you're just outside the vessel, inflate the balloon, give a little topical thrombin patch right there on top of the vessel. So if you can't do that, by the way, if you're unsuccessful in crossing, then you take a blood pressure cuff, you inflate it at 50 millimeters of mercury below the knee for 15, 20 minutes, and that's generally fine. Remember, there's not much flow at that point, so hemostasis is not difficult. Let's move on to, well, this is just completing that case. So you can do, obviously, retrograde approaches from other, other access points. This is just a fun case of retrograde approach from the pedal access, and coming up, and this is actually with a 6 French slender sheath in the foot, and this is the only way that you're going to be able to do a reverse cart and get perfect placement of a retrograde place supera stent, as you can see here in this location. So pedal access certainly is possible. So I think I probably exceeded my time. You can go through wire catheter. Most of the time we start with wire catheter. You want to have a couple of dedicated CTO devices. We're very comfortable going, subintimal, like I said, and going through that progression that we saw, understanding that rendezvous approaches are often frequent, and we really like that retrograde P3 approach. Thank you for your time.